I am Dr. Santhosh George Thomas, one of the neurosurgeons in Macquarie University Hospital. I have a special interest in skull-base surgery with a focus on pituitary surgeries. The pituitary gland is also called the master gland. It's a tiny organ about the size of a grape that produces hormones that influence other glands of the body, like the thyroid and the adrenals, to secrete their hormones, thus influencing every part of the body. Pituitary tumors or adenomas are, or they're called PitNETs now. They're benign tumors that arise from the pituitary gland. These are fairly common and can happen in about 1 in 10 people. These tumor cells are mostly non-functional, which means they do not secrete any hormones. But they can also produce hormones in some instances, leading to an excess of hormones, leading to hyperpituitarism. Now, both need to be controlled with either medications or surgery. I'd like to talk to you a bit about pituitary surgeries today. Surgery is about going and debulking the tumor and trying to remove the compression that the tumor has on the adjacent structures. The optic nerves, they meet above the pituitary, and hence a pituitary tumor can compress the optic pathway, and this is the most common presentation with a progressive visual loss. Pituitary tumors are managed by a team-based approach involving an endocrinologist, a neurosurgeon, an ENT surgeon, and sometimes the radiation oncologist. When offered surgery, it's performed by a neurosurgeon in conjunction with an ENT surgeon. I work with Dr. Arjuna Ananda, the ENT surgeon, for these cases, and we manage them together in the operating room. These are the scans of a patient who presented to us with a very large pituitary tumor going up into the brain, causing progressive visual loss and a near total blindness over a relatively short period of time. We approached it through the nostrils and prevent opening of the head in most of these cases. The endoscopic approach is less invasive with less tissue dissection. An endoscope guides us through the nose, through the nasal sinuses, into the cellar where the tumor is actually located. The endoscope provides excellent lighting and magnification and a 4K resolution to the images. This in turn increases the margin of safety and accuracy and helps us to delicately separate the tumor out from the normal gland. We pay very close attention to the optic nerves and the carotid arteries to make sure that we're absolutely safe.
What do we do when we remove the tumour? We're left with a large hole, potentially, and we have to do something to fill that hole in. So what we use is tissue harvested from inside the nostril, and it's called nasal tissue, and we rotate it on its blood supply and use it to fill that gap in. And that's all that's required.
So this is the post-operative scan. We have the pre-op scan on the left side and the post-op scan on the right side, where you can see a large tumor on the left and the post-operative scan showing a complete resection. At the base of the tumor, we can see the vascularized pedicle flap that has been used to reconstruct the skull base. This patient made an excellent recovery and her vision improved to normal. So endoscopic surgery is a minimally invasive technique that allows us to achieve a good resection of pituitary tumors with good skull-base reconstruction. This is an illustrative case and the results cannot be translated to all patients. The treatment strategy always varies according to the patient and their specific condition. Please talk to your medical practitioner for further advice.